Kia ora koutou, and thank you for joining us tonight. My name is Lydia Hemingway, and I am the CEO of Fertility New Zealand, and it gives me great pleasure to be here this evening with you as we bring endometriosis and fertility, this webinar to you this evening. March is International Endometriosis Awareness Month, which is endometriosis is a common inflammatory disease estimated to affect 176 million individuals worldwide in their reproductive years. Symptoms usually include period pain, pelvic pain, sub-fertility, or infertility. Big thank you to our webinar series sponsor, Merck, who assist us and support us here at Fertility New Zealand in bringing this webinar series to you each month. Fertility New Zealand is a national charity, and we walk alongside all people facing fertility challenges. We do this through providing support and information services and advocating for our community. You can contact us through our helpline or regional and topic support groups, and you can connect with us on social media through Facebook, Instagram, and LinkedIn. Our website is fertilitynz.org.nz with all of our contact information on there. You can also join Fertility New Zealand as a member. Membership is free, and by joining, you have access to some additional resources and you support the valuable work that we do. Please visit our website for information and resources, fact sheets, newsletters, videos, webinars, recordings, and more. I'm really delighted tonight to introduce and welcome Dr. Simon McDowell. Simon is based in Wellington and sees fertility and gynecology patients at Fertility Associates. He also works at Wellington Public Hospital as a senior lecturer at the University of Otago and is a clinic advisory committee member for Endometriosis New Zealand. Simon has a special interest in the laparoscopic management of menstrual disorders, female infertility, and pelvic pain, including endometriosis. If you have any questions as we go along in the webinar, please type them into the chat box or on Facebook Live, and we'll come to them at the end of the webinar as time allows and if the questions haven't already been answered. We hope you enjoy the webinar. Over to you now, Simon.
Thanks, Lydia, and thanks, Kate. I'm Simon. Thanks for inviting me to take this talk. And I hope you guys learned something and we can get through some of these questions at the end. So I'll try and get through the talk, show some pictures. I'm quite a visual person. I think it's quite nice just to visualize what's going on and go from there. Right, so we'll get to it. So what is endometriosis? The endometrium is the inside lining of the uterus. So that's this sort of red area here. And that's a bit which thickens and thins with menstrual cycles. That is something that sheds off and comes away when a woman menstruates. And it's also where an embryo, whether it's come through natural fertilization or IVF fertilization, so in the lab, that's where the embryo implants and grows. So the endometrium is a really important part of the reproductive process. When that endometrial tissue grows on the outside of the uterus, and you can see here the little red lesion growing between the rectum, the bowel, and the uterus. There's some growing on the bladder here. This is the bladder, some growing on the ovaries. This is just giving a bit of representation that it's that normal lining growing on the outside. And it's inflammatory, okay? So it's inflammatory. So imagine you cut your arm. I'm a hockey player, cut my arm playing hockey on the old sand turfs, which were pretty gross, really. And then it gets infected and it gets all inflamed. It looks angry. That's kind of the same process with endometriosis. It's not infective, so it's not infection, but it's inflammatory. There's angry tissue there. Oh, so I've just got to figure out how to move that along. So how common is that? We've already sort of talked about that. Within New Zealand, about every 10th woman will have endometriosis. And so that's really about 120,000 women or something like that. 1 in 10 women don't need intervention or don't need surgery. You know, you need to individualize the patient's situation to determine what the best course of action may be. Some people may have very little symptoms and need no course of action. Some people may have significant severe pain and need a much more complicated course of action and fertility treatment and that kind of stuff. So endometriosis is not one thing. There's different types of endometriosis and there's different levels in the spectrum, if that makes sense. So this is a lovely normal looking uterus. So this is looking through the belly button with a camera, a laparoscope. So this patient's having a laparoscopy. I hope you guys can see my cursor moving around, but this is the uterus here. This is an ovary. This is a fallopian tube. This is all very normal tissue. Okay, absolutely normal cavity. You can see here this little, there's like a bubble on the ovary, and this woman's about to ovulate. So she's got a pre-ovulatory follicle, and ovulation is when that little cyst bursts and the egg gets thrown out. And if she's trying to get pregnant, then the egg may make its way into a tube. The sperm meets it, creates an embryo, and then over the course of about a week, it makes its way down into the uterus where it implants and grows within that endometrium. So that's normal looking pelvis. It all looks very clean and healthy. Oh, it's coming very slow. This is the appendix. And, you know, uncommon sites of finding endometriosis is on the bowel, the diaphragm, the lungs. You can see here the appendix should be like your finger, sort of out straight, and it's all curled up like a pig's tail. And that's endometriosis growing within the appendix, and it's curling up into a ball because it's fibrotic, so everything gets drawn to it. It's going to go back to that other slide. Yeah, so common sites of endometriosis are growing in these structures here beneath the uterus, what we call the peritoneum. This is what we call the pelvic sidewall. Also down in here, it's what we call the pouch. So that's the area on the other side of the top of the vagina. So you've got the top of the vagina, and then on the inside, on the other side, is what we call the pouch, and that's areas down here. These structures down here are what we call uterosacral ligaments, and those are also very common sites for endometriosis. Endometriosis can grow on the ovaries as well, and I've got some more pictures about that. So I've talked about uncommon sites of endometriosis growing on the bowel, scar tissue. Women having had a cesarean section will occasionally, very occasionally, lots of women have Caesars, they don't get these problems, but very occasionally we'll see endometriosis growing within the scar of the cesarean section. And you know, it's uncommon, very uncommon, but it does happen. It can grow up in the lungs. Women get sorry, let's turn that off. A woman can get it growing in the lungs. They can get cyclical pain up in the sort of, you know, this part of the tummy there, and that's obviously very rare as well. So it is something that can grow in lots and lots of different places. It's even been identified in the brain. I've never even seen that, but apparently it's you know, there's tissue that has actually manifested even in those environments. This is endometriosis. So this is the uterus up here, and this is sort of endometriosis here, sort of mild disease, sort of growing, and it's almost like someone sort of spray painted it with this tissue, and that's red puckered lesion. That's endometriosis. This is looking down in the pouch, and you can actually see there's actually a lesion over here as well, and there's another picture coming up in a minute. So you can imagine it looks just a bit angry, a bit hostile, and we'll talk about that, how that may cause pain or problems with fertility. This is another sort of lesion there. There's a classic sort of red-black lesion, so that's sort of endometriosis around there, but this whole area around here is endometriosis, okay? And you can even see a little bit up around there. I'm just making sure that's not the moderators telling me they can't hear me or something. No, I don't think it is. All right, my internet connection is a little bit unstable, so hopefully I don't drop out. Oh, I can't see the cursor. Thank you. Just saw that there. Okay, so I don't have a pointer, sorry. No. Can you guys... Oh dear.
Hi, Simon.
Hi.
Hi. Just on your bottom bar down the bottom, there's a little arrow. If you click on that, that will give you the cursor.
Yeah. Thank you.
Thanks.
Cool. Can you, I'll just close that whiteboard. Okay, thank you. Thank you. Oh dear. Can you restart there? There we go. All right. Pointer. All right. Can you see that now? No. I hope you can see that now. Yes, oh, cool, thank you. So this is endometriosis here. You see this is the fallopian tube here, and this is another sort of red lesion, and it's little sort of puckered lesion. And again, this is beneath the ovary. So that area is about sort of that big, and we've sort of zoomed up on it a wee bit there. It's a bit slow between slides, sorry. This is a zoom up of that one we had before. And you can see this is that pouch of Douglas. This is the rectum here. So the rectum sort of coming down straight, the vagina's on the other side. And this little angry red lesion is about sort of that big. You can see everything's being drawn into it. And, you know, it's got a surface area. So it's actually, you know, quite a large lesion there with everything drawn into it. And this woman was getting a lot of issues with when she was having pain with their periods, especially premenstrually, and she had a bowel motion. Then as the sort of the feces went past that, it caused a lot of problems. It caused a lot of irritation. She also had a lot of problems with intercourse. So, you know, the penis is hitting the other side there, and when she's having penetrative intercourse, it's very uncomfortable. And again, so, you know, endometriosis can cause problems with bowel motions, especially cyclically, and also with penetrative intercourse. This is that very normal looking pelvis we could see, the ovary, the uterus. This is really bad endometriosis. Okay, so this is the ovaries full of this sort of black fluid. It's called an endometrioma. Another term people might have heard of is a chocolate cyst. And you can see here the ovaries are stuck to the uterus. So if we go back to that previous slide, this ovary is, you know, super glued down here. The other ovary is super glued down there, and that rectum or that bowel down there is actually super glued up there. So it's all drawn together in a mass. And this is someone where we could actually see the disease on an ultrasound scan. We could put an ultrasound scan inside the vagina and have a look, and we could see the cysts on the ovaries, and we could see how everything's stuck together. Okay, so that level of severe disease we can often pick up on a scan with some, you know, pretty high certainty. You know, some of this more milder disease we talked about back here, you know, like that there, we won't see on ultrasound scan. So if you've got mild endometriosis, a normal scan doesn't say you don't have it or anything like that. But if you've got really bad disease, we may be able to find out a bit more about actually what's going, how bad it is, and that can actually help when we're planning surgery. You know, what kind of surgery do we plan? All right, and this is as we've freed up that same patient. You can see that black fluid coming out. So that's that chocolate fluid. It almost looks like chocolate. You can see why, you know, why it's called that. Why is it sort of chocolatey? It's old blood. So it's blood that's kind of changed in its nature and become a much more brown picture as it's slowly absorbed. So that's quite a classic finding. And this is as we were getting a bit further. Oh, so there's another, I did have another slide where we did show and everything sort of freed up and come apart there. So endometriosis can cause severe menstrual pain. It can cause mild menstrual pain. It can cause pelvic pain, so pain in other parts of the pelvis. It can cause infertility and sub-fertility. Sub-fertility is trouble becoming pregnant, and infertility means you just can't get pregnant. It can cause bowel problems. Women with irritable bowel and people without irritable bowel may, commonly have, may commonly have irritable bowel misdiagnosed. You know, it's not irritable bowel; it's actually endometriosis causing it. There is some overlap in symptoms there. Irritable bowel is very common, so lots of people can have both. You can have endometriosis and irritable bowel. Perhaps they do interconnect a wee bit. Painful intercourse, as we talked about, pain with ovulation. You know, some women will find that, around they're good between the end of the period and up until ovulation. And then ovulation, get a little bit of sharp pain, just uncomfortable and aware. And then there's just a gradual escalation in symptoms up until the period. And then often say the day before the period or a couple of days before, and with early bleeding, it's really bad. You know, those are the really bad days. And as the bleeding seems to tail off, you know, the pain seems to improve, and then the person gets a bit of a gap, you know, a bit of a break from their symptoms for that next sort of 10 days or so. Can cause bladder pain as well. There's something called bladder pain syndrome, and endometriosis may be the trigger for lots of other problems. Painful bladder syndrome, irritable bowel syndrome, painful pelvic floor, tight pelvic floor muscles. They are a very significant cause of pelvic pain in women with endometriosis. So, endometriosis can cause complex pain. What does complex mean? It basically just means that there's a lot of things causing the actual issue that person's having. It's not just endometriosis. It's not just painful pelvic floor. There's other things going on. But endometriosis, can very commonly be the underlying trigger. But you can't just treat endometriosis to get that person's quality of life better. You've got to look at all of the different facets of what the problems may be. So sub-fertility, infertility, that's really what we're focusing on today, but I think it's hopefully quite good just to get a bit of an overview about this other stuff. And the pattern of symptoms people get is very variable, okay? It's really hard for GPs to pull everything together in 15 minutes. I know that, there's a common delay in diagnosis for endometriosis, which is something we just really need to continue to work on. But, it's hard. Some people won't immediately attribute some of the symptoms they're having to their periods or endometriosis. And people may go down a bit of a different sort of pathway, and it's later that it's found out. And more awareness for everyone, patients, doctors, GPs, specialists is hopefully going to help us, see earlier diagnoses and help people out earlier. Right, so 50% of women that we see with infertility may have endometriosis. Okay, that doesn't mean that's the number one problem that's causing their infertility, but it may be at least associated with the problem. For many people we see, that is the underlying problem. Okay, but it may be a bit multifactorial. 30% of women with endometriosis will experience infertility. So it's not that endometriosis will cause infertility. It's a common cause of infertility. So if someone gets diagnosed with endometriosis, when they're 23 years old, those people should be aware of the potential impact on their fertility rather than have this expectation that they're going to have problems. Does that make sense? And at the surgery, you can normally get a bit of a gauge. Hey, the tubes look good, the ovaries look good. Hopefully, we're going to be okay. But different to see if you see someone with those really big endometriomas and everything's really stuck. The impact of their fertility in the future is likely to be more profound, and we may be more direct about the potential impacts. Okay, so endometriosis is a common cause of infertility, but it's not that you will have problems if you've had that diagnosis made. Okay, it's about awareness and knowing where lines of the sand are. When do I seek help? When do I seek attention? What's the next slide there? How does endometriosis cause infertility? Well, that's not a clear answer either. And it's really different for the different stages of disease. So some of those earlier pictures I showed you where there was just that sort of spray painting endometriosis, that's more mild, say stage 1, okay? Stage 1 disease is just small amounts of patchy disease, which is quite superficial and not growing into the deep tissues. Stage 4 is like that picture I showed you with those endometrioma and everything all stuck. That's really bad disease, okay? And mild endometriosis, it has a mechanism of how it may cause infertility, and we'll talk about that. But severe disease has other impacts, okay? I just want to have a look at the slide there. So mild endometriosis, that's inflammatory. So it's really about an inflammatory environment. There's all these toxic substances around which are affecting all the parts of the fertilization process. The ability of ovulation to work properly, the ability of the egg to get to the fallopian tube, the ability of the sperm to get to the egg. The sperm fertilizes the egg towards the end of the fallopian tube, then makes its way down. It may affect the motility of the sperm. It may affect the actual fertilization process. It's just this toxic environment which is altering that very delicate, fragile environment which is required for good fertilization to occur. Okay. As we get into, Yeah, and it can also actually affect the ability of the embryo to potentially get down the fallopian tube. And finally, it may affect the receptivity of the endometrium, so the ability of the endometrium to accept the embryo to implant. That's an area of a little bit of contention, but we do have some concerns about that affecting the receptivity of the endometrium, and we do, have a think about this with IVF treatment when we're doing that. Once you're getting to more severe disease, so this is that patient we see with those endometriomas where we've started to try and free everything up. You can see the rectum there, it's all stuck together. In that more severe disease, the anatomy can be distorted and affected. So it can cause the tubes to be blocked. The tubes are just totally stuck. The egg and the sperm just can't get together. So it can also affect the motility of the fallopian tube. So the egg and embryo just can't get down the tube. But when you've got these toxic endometriomas, that may affect ovulation. That ovary just doesn't work very well at all. It may affect egg supply. So especially when there's endometriomas there, we do find that can adversely affect a woman's egg supply. Intercourse can be really uncomfortable, especially for those women that are really suffering from deep pain with penetrative intercourse. But they just, the ability to have regular intercourse, which is really what's required to make sure you're covering all your bases in terms of chances, can be more difficult because it's uncomfortable, it's painful. So there's a lot of different mechanisms there, and it's different by the different stages of disease. When we're assessing someone's fertility, we look at the sort of 3 key ingredients which are required for someone to have a pregnancy. Okay, and I talk this framework with heterosexual couples I'm seeing, same-sex couples, everyone. This is the kind of framework we talk about because we need these 3 things to be working for us to create a healthy pregnancy. So that's eggs. So we're looking at egg quality. We can't measure egg quality, unfortunately. We just look at age and get a bit of an idea from there. We look at egg supply, we look at ovulation. And in terms of the environment, we think about fallopian tubes, endometriosis, polyps, fibroids inside the uterus. Sperm, more simple. We look at their numbers, their motility, and the ability for the guy to deliver that sperm. Is there any issues with erections, ejaculation, that kind of stuff? So if we've got a patient here, this is just an example of a potential patient. She's the female, she's 33 years old. She's got regular menstrual cycles. She's had a day 21 progesterone, and that's a blood measure we do to check if someone's ovulating. And it's 35, and that means she's ovulated nicely. She's ovulating well, okay? And given she's got regular cycles, we can extrapolate that she's likely ovulating every month. Every now and again, women might miss the odd ovulation, but as long as they're having regular sex and everything's working okay, it should work out. AMH 29, that's just a good egg reserve level. Okay, roughly speaking, between 14 and 30 represents good egg reserve levels, but we do use a centile chart to how to explain that a bit further. We'll come into the environment last. In terms of sperm, the guy's got normal sexual function and his semen analysis is within expected limits. Okay, so without even seeing this patient, we can see that she's young, she's got a good egg supply, she's ovulating, the sperm count looks good. So you're already getting a focus onto that environmental factors. Okay, so for this kind of couple, even as I'm reading through the referral, I'm already thinking, right, I really need to focus on the pelvic environment, sexually transmitted infections, painful periods, heavy periods, not just endometriosis, but that whole kind of spectrum. For this patient, she had premenstrual awareness. So she just knew her period was coming. And that can be very common. It can be normal, but that can be a bit of a red flag, especially if it changed over time. I saw someone today or yesterday where she said, oh yeah, I'm really aware my periods are coming, and I didn't really have that in the past, but I can tell I'm going to get it later in the week. I get bloated, around that, just before menstruation and with menstruation, work from home for a few days, continues to work, but, it's just not that pleasant, and, the flow can be really heavy. And, we do maybe have more ability to work from home now. So for this kind of patient, she's not taking time off work. She's not like, I can't work. She still works, but she's clearly not as functional perhaps as she might be otherwise. You've also got to look at infertility as a symptom Okay, so think of infertility as a symptom, and really, when we're looking at problems, some people just have pain, but they've never tried to get pregnant, so we don't know anything about their fertility. Some women just have infertility and actually very little pain. Okay, that's, their biggest problem is they're not pregnant, but actually when we look closely at their cycles, they haven't registered that they're perhaps outside of the ordinary, and perhaps it is affecting the individual more than perhaps they think. But then when you add infertility, it's like, okay, actually we're actually quite symptomatic. So for this patient, by a process of exclusion, we've really got to her periods and had a close look at them. And for this patient, we might say, look, actually, we think endometriosis may be the cause. Okay. We've discussed treatment options and everything, but given that she's young with good egg reserve, ovulatory cycles, good sperm, we would potentially look at surgery as a treatment for infertility. Okay. What we would do is go and do a laparoscopy, check the fallopian tubes, look for endometriosis, and like those pictures we showed, we would excise it, we would remove it and cut it out, taking great care to avoid damaging anything and trying to minimizing the risk of scarring and adhesions. Okay. What I would do when I'm seeing that patient next is use something called an endometriosis fertility index. So this is a very well validated model internationally, where we work out where the endometriosis is, how bad it is, and we also look at the age of the female and how long that she's been suffering infertility, and then we can work out kind of roughly what the chances are of becoming pregnant naturally after IVF treatment. After surgery. So you can see here. A key thing is whether the fallopian tubes are affected, whether their ovaries are affected. Because if the fallopian tubes are normal, then that's hopefully a really positive sign that person will score better. We end up with a graph like this, okay? And you can see here time trying after surgery and the percentage chance of people that are pregnant, okay? And you can see here if someone has mild disease, everything else looks good, only been trying for say 18 months, not 10 years, then they may score higher on the graph, meaning that over a 6 to 12 month period, they've got maybe 40 to 60% chance of having a child. And you might think, gosh, only 40 to 60, but hey, for that couple that have been trying and not getting pregnant, by the time it's been 18 months and all that kind of stuff, their chances of actually getting pregnant are probably about 1 or 2% per month. So we're going from that, up actually very significantly, okay? Other people we operate on, and we might say, hey, your tubes are not looking good. Hey, you're 38 years old. Well, actually, we may score much lower on the graph, okay? And this is quite useful for planning going forward. How long do we give it before we look at plan B, which might be insemination treatment, IVF treatment, that kind of stuff. And you can imagine if you score lower on that graph, well, we might just get on with things a lot sooner. If you score higher on the graph, well, we'll potentially give it a bit of time and sort of reach a bit of a agreement of where that next line in the sand is. Okay. Just having, going to talk about a few things going on. Some people will talk about, let's say this couple that we talked about before, let's say she's, let's say, for example, she's very symptomatic. She's got quite extreme symptoms. But the guy's got a really low sperm count. He's got a really low sperm count, and he had something called undescended testicles. And clearly that's the biggest factor as to why they're not becoming pregnant, okay? But endometriosis could be playing a role as well. But the sperm count's so low that we're going to look at IVF treatment very, much earlier anyway, okay? Now for that couple, she has suspected endometriosis, but there's a circle around, this area here as well. Will doing surgery improve the outcomes of IVF treatment? And the answer is we do not have evidence to support it. To support that. So surgery for infertility is about improving the chances of natural pregnancy, okay? But we would not recommend doing it to improve the chances of IVF success, okay? Caveat, every now and again, women will have massive cysts on their ovaries, big endometriomas, and you actually can't do a good IVF cycle when the ovaries are so badly affected by those cysts. And we kind of have to deal and fix up the ovaries before we can stimulate them, Okay. Right, let's just move on to the next one there. So one thing patients suffering from infertility with endometriosis will think about is their future fertility. Okay, so they're not trying, but they want to make sure they have the best chance of getting pregnant in the future. How I approach that, let's say I see a 25-year-old woman, I'm just picking an age out of the hat. She's not ready to have kids, but she's thinking of trying, down the track. What would I say to her? And look, I've looked at, had a look at everything. The tubes look pretty good actually, so I'm hopeful she'll be able to get pregnant. What I would say to her is look, if in the future you're trying for a child and you're not getting pregnant, seek help more readily. Okay, so seek help perhaps after 6 months of trying, rather than giving it a full year. For someone who's say 32 would say, hey, give it a whole year. If you're not pregnant, come and see us. We're not going to assume it's this or that. We'll check sperm, we'll do a thorough evaluation. But for someone with a history of endometriosis, I would pull that back. Okay, 6 months. If the person's got a history of endometriosis and she's 38 years old, well, you can maybe even pull it back a bit more, even to 4 cycles. Okay, I think if someone's worried or concerned, just seek help early. Just go and have a discussion. It doesn't mean we'll jump in and do something. Some people, I know sometimes people get the advice as I've been told I should have kids early. I should try and have my kids before I, turn 30 or whatever, because of endometriosis. And I must admit, my approach to that is I find that that's not the advice I would recommend, because I think people should get pregnant when it's the right time for them. All people should have kids earlier rather than later in life. I think that, age is the biggest cause of infertility, advancing age. So really every person should be having a child, ideally by their early 30s, especially if they want the best opportunity of having 2 or 3 kids and not need the help of someone like me. We use a term of planning for your last child, not planning for your first child. What I mean by that is we see people where the first kid came around sweet as, no problem, but they were 35 when they were trying for their first. And by the time they're trying for their second child, they're 37, 38, and time's just advanced, okay? And then they can't get pregnant. And the only thing that's happened is they've reached a steep part of the fertility graph where there's just less availability of good quality eggs, okay? So, yeah, I wouldn't say get pregnant, try and get pregnant in your 20s, unless it's the right thing, you're in the right relationship, all that kind of stuff. But be aware that endometriosis could have an impact on your fertility in the future, and seek help earlier, okay? Egg freezing. So we now have the ability to freeze eggs and really, kind of put a bit of a timestamp on someone's fertility in a way. Egg freezing's not for everyone. There's cost involved. For a round of egg freezing is about $11,000. The younger woman freeze eggs, probably the less likelihood they'll come back and use them. A 25-year-old freezing eggs, may well have no fertility issues and will get pregnant, with their partner in the future without any issues. But once they're getting someone who's a bit older, maybe 35 years old, they're more likely to potentially have issues, and having eggs frozen is maybe more ideal. So where's the balance? Where's the time to freeze eggs? Look, you got to individualize that. If someone's got a really low egg reserve, a history of endometrioma, disease affecting the ovaries, well, yeah, maybe freezing eggs in the 20s may be something to consider. Okay, I'm not saying they should do it, but it should be something to consider, taking advice from their, fertility specialist. Whereas if people have no history of any, problems, endometriosis, whatever, then freezing eggs, as long as they've got good egg reserve levels, perhaps they could look at doing in the sort of, early to mid 30s, perhaps. But you've got to totally individualize that situation. There's no hard and fast rule, and there's cost involved, and many people would love to freeze eggs, but it's just not something that's within their means. Okay, so egg freezing for women with endometriosis, really when it's been affecting their ovaries, that's where you've really got to have a think about egg supply, perhaps talk to a fertility doctor and get it measured. So I'll show you the next slide there. This is an endometrioma. So this is a chocolate cyst, and you can see a variant tissue there. And you can see there's no capsule. See, it's all very irregular. It's not like a clear capsule. And that's why when you remove endometriosis, endometrioma, it can be quite damaging to the ovary, okay? The problem is you're stuck between a bit of a rock and a hard place. What I mean by that is that the ovary is already damaged by the disease, okay? But when we strip out the endometrioma, we take out a little thin layer of tissue there, but because that thin layer is super glued to the ovary, you can remove eggs with it as well. So we sometimes do see that a woman's egg supply does drop once they have endometriomas removed. What I advise my generalist colleagues is if they're operating with a woman with endometrioma, is perhaps those women have a chat with a fertility specialist first and be aware of the option of egg freezing and how to access it and whether it's the right thing for them. Sometimes I'll see those patients and I'll say, look, yeah, I think, your egg reserve's low, but hey, actually, we're not going to be able to stimulate your ovaries very effectively at the moment because of these big endometriomas. Other patients might be that the endometriomas are quite small and we can safely access this white tissue where the eggs are to stimulate and harvest eggs. And maybe we do it before surgery, just in case we see an adverse effect on the egg supply. Okay. So again, no hard and fast rules there. It's a difficult, you've got to individualize it with the individual. AMH, so this is how we measure egg reserve. It's called anti-Müllerian hormone. And we use a chart like this to sort of delineate where someone's at. Okay, so you can see here that middle line's the 50th centile. You've got the 90th centile here, the 25th to 10th. Now this measures how full the jar is of eggs, not the quality of those eggs. Okay, so I'll go forward and then we'll come back to this chart. Women are born with all of the eggs. Okay, and imagine a jar of jelly beans, and you've got red jelly beans, green jelly beans. Green jelly beans are the good ones, green go. And when you're older, there's lots of these green jelly beans, but still the occasional red one. And the red jelly bean, the red egg, is a chromosomally abnormal egg. Okay, so the egg that has errors in the chromosomal complement. It can't become a pregnancy, or if it does, it'll miscarry. And as a person becomes older, their egg supply falls, and there's a higher proportion of these red eggs. Okay, and that's why you can see here. So with that, that's why we know that as a woman becomes older, her fertility drops and the chance of having a miscarriage increases. And the reason why people have more miscarriages as they become older is to do with these red eggs. Okay, that by far that's the most likely reason. Okay. So for people who are looking at egg freezing, we know that there's an age-related sort of amount of eggs we may need to have a percentage chance of a child. So for a 30 to 34-year-old, we may need, I've got a bit of a graphic here, or 35 and below, 36 and below, I should say. We need maybe 10 eggs to have a 50% chance of a child from those eggs. Whereas an older person will need more eggs because there'll be more of those green eggs. Okay. How many eggs might we get from an egg freezing cycle? Well, it depends on someone's AMH level. The higher the AMH, the higher the amount of eggs we may get. Okay. The lower the AMH, the lower the amount of eggs we may get. Okay. And it's difficult to get that perfectly. You can see here it talks about 80% chance of 6 more eggs if you're in the green zone. Now, the AMH, as we talked about, just measures the amount of eggs. It doesn't measure the quality of those eggs. So a woman who's never tried for a baby and she's got a low AMH, let's say it's 1, well, she may be totally fine. She may get pregnant without any trouble whatsoever. These low numbers of eggs, hey, but the eggs that are there are really, really, really good. Let's say you've got a 44, 45-year-old woman with a high AMH way up here. In a way, that's a good thing for that person wanting to get pregnant. It's good to have a lot of eggs, but unfortunately, there'll be a lot of those red eggs, a lot of them. There's so many of the eggs will have chromosomal issues, and it's very hard to get someone pregnant in that age group. Okay. Right. So I think I'm reaching the end of what I was going to talk about. So we'll open the floor for some questions. really, what I want to get down to as well, before we talk about questions, is when do we do surgery? When do we look at surgery? The first thing is we do surgery for someone who's suffering from pain when they're not getting symptom control. Okay, so symptom control means there's just no control. How do we get symptom control? Hormonal treatments, the pill, marinas, we would try those things. Okay, for some people they won't tolerate hormonal treatments. It doesn't suit them, and that's okay. They don't have symptom control. The other reason we operate is infertility. People are struggling to get pregnant, as we talked about, and we think endometriosis is the cause. Okay. Some people have both. They have infertility and they're in pain when you really look at their symptoms. Okay. But what I wouldn't operate for is fertility. Okay. So let's say I'm seeing a 25-year-old woman and she has got suspected endometriosis, given a pattern of symptoms, but she's getting symptom control with, say, the oral contraceptive pill. Okay. Well, I would not advocate for surgery there with a view to making sure she can get pregnant in the future. Does that make sense? Because we don't know if there's a problem at the moment. That woman may have very good fertility, and it may be, even though she's got endometriosis, she's in that 70% that doesn't have any problems. Surgery can cause scarring and adhesions. While we do it to improve fertility for those suffering infertility, it could also have some adverse impacts on people as well. The tubes could get a bit scarred. There's always scarring after surgery. Surgeons will create great care and attention to avoid damage to those things. But if the woman's not really symptomatic and she's never tried, I would generally avoid operating. Okay, and obviously we need to visualize that and have discussions about it. So we operate because someone's in pain and they're not getting symptom control. We operate because they're suffering infertility and we think that's the cause. Having explored all the other options, sometimes we have both, but I would avoid surgery with the view to improving fertility for someone who has no fertility problems that we're aware of. Okay, and that can be a bit of a difficult concept to grasp, but the thing I'd use, if it's not broke, don't try and fix it. So if we don't know there's a problem with fertility, don't try and fix that problem. So know an endometriosis woman who have endometriosis, seek help if you're not pregnant after 6 months. Okay, unless I've said to someone, hey, give it even less because it's really pretty bad. Come back sooner. If someone's had an operation for infertility, for endometriosis, then doing another operation, is highly unlikely to improve their fertility. Okay, you get one good go at it. Does that make sense? So I'd always advocate repeated surgery unless someone's suffering from pain. Surgery to improve IVF success, I would avoid that. Okay. Caveat again, if we've created good quality embryos and we keep putting them back and they're just not working, we may have to backtrack to endometriosis as having a possible negative effect on receptivity of the lining. Okay. So generally people have had 3 embryos back without success. We just might have to backtrack to that. And sometimes we need to remove endometriomas before IVF because they're too big and they can cause problems. But we don't routinely remove them because that could lower egg supply. Okay, so you've got to weigh up the pros and cons. Right, so that took a fair while. So we better get to some questions, but I hope that's helpful. So Lydia, cool, was one there already. How come I have all these symptoms but nothing showed on surgery? Yeah, that's kind of, I often say to people who I'm operating on them, when I think endometriosis is the cause of infertility, we talk about risks and complications of surgery, we could damage bowel, unlikely and all that kind of stuff. But, I do sort of make a comment along the lines of, gosh, in some ways, the biggest complications, we don't find anything, because then it's, from a fertility perspective, that's kind of disappointing because you want to find the cause and move on to whatever is the next step is. If it regards to pain, and then you find nothing on surgery. So pain can be caused by a number of things, okay? So endometriosis, may be the cause of pain, but there's other things that can trigger some of those problems. If I think someone's got endometriosis and then I can't find anything and they're really in a lot of pain, I'll really look closely at their pelvic floor. Pelvic floor muscle pain can be cyclical, okay? It can present itself like endometriosis. And there's a number of different things that can lead to pelvic floor muscle pain. endometriosis is one trigger, previous trauma, even chronic UTIs, you know, lots of different things can cause that triggering of that pelvic floor muscle pain. So I think if it wasn't found at surgery, I think you need to really carefully explore some of those other things. Yeah, other things, sensitization, where the body's overreacting to pain signaling, you know, looking at bladder pain syndrome, looking at the bowels. Yeah, I hope that's helpful. But yeah, I'm sure you're frustrated. It's yeah, frustrating. What if you have stage 4 but clear tubes? What are the chances of a child there? Well, I would use that EFI, the Endometriosis Fertility Index. So I would use that to gauge where you're at. And the person would score lower on the graph given the severity of the endometriosis, but they'd also be pulled higher on the graph because of the because of the tubes looking okay. So, you know, for that person, we'll go back to the EFI. I'll see if I can bring it up. And I don't know for this individual, but maybe they score somewhere midway on the graph. Does that make sense? So you can see here, you get, you know, or go age and stuff as well, but you get less surgical score here, you know, given the severity, but then the tubes are good. So you might score higher with that, what we call least function score, but you're taking those other factors there. Okay. So that's how I'd explain it. I'd look at it carefully there. Would you not recommend surgery when endometriosis is in the uterus? Oh, so that's something called adenomyosis. That's where the inside lining is growing into the muscle. The problem is the surgery is very, very difficult. The only way to adequately remove adenomyosis is to do a hysterectomy. And that's not very good for fertility for obvious reasons. Adenomyosis can be diffuse, where it's all over the uterus or within the muscle, or it can be focal, okay, where there's a nodule of disease. Diffuse endometriosis, you can't surgically resect, okay, because it's everywhere. Focal endometriosis, where there's a real focal amount of adenomyosis, is quite rare, but it does happen, and we may recommend removing those in selected circumstances. The problem with adenomyosis is that we're picking it up way more commonly now because the ultrasound machines are so good. They're really good. So we're finding that, you know, some women may have features of adenomyosis on scan, but they actually have no trouble with fertility or any issue whatsoever. So I believe you're talking about adenomyosis, and that's like a first cousin of endometriosis, and that is difficult to treat surgically. Okay, it's difficult to treat surgically when you're trying to preserve fertility. So I do work in public in Wellington. The public health service is stretched. It is, and you know, I think it's not a lot. You know, all the regions in New Zealand, I think, are struggling with the burden of care. To accessing the in public, then it's a GP referral has to go to through to the public health system, and then there's a prioritization team, okay, and then the people prioritizing, you know, because they can't offer appointments to every single person from the GPs, they sometimes will have to write back to the GPs and try this and try that. So you need to talk to your GP and get a referral, and you know, and then it would be prioritized. So I couldn't promise that anyone would be seen there, and that is, yeah, the harsh realities of where things are at with the public health system at the moment. You know, it's struggling. You know, it's struggling. Even if you see me in private and say, I'll pay to see you, Simon, I can't access the public surgical wait list. I need to refer into the hospital for an assessment. So it's hard. Yeah, it is hard. But we are seeing patients in Wellington for endometriosis and problems. But you know, the GP needs to refer, and then it's prioritized, and they'll, you know, the people doing the prioritization will send the referral in the appropriate pathway. Hi, Doctor. Endo symptom management. Would you recommend someone who is trying to get pregnant? Yeah, well, it's bloody hard, isn't it? Because you can't go on the pill, you can't have Mirena because that doesn't help. So for someone who's trying to get pregnant, who's suffering from symptoms, you really, all you can do is look at pain management, okay, or look at pain relief, sorry. So really taking pain relief when you need it. You know, we can't use anything hormonal, okay. Sometimes, you know, it's important to look at those other facets of complex pelvic pain. So look at the pelvic floor muscle. Will seeing a specialist physiotherapy be helpful? You know, that's something that we'd look at. But for someone who's trying to get pregnant, who's got pain, then we may look towards surgery more readily, because you've got two symptoms, you've got pain and infertility. And even if you haven't been trying for as long, well, potentially we would look at looking at surgery earlier, okay? So it's pain relief, and then it's really looking at perhaps earlier recourse to surgery, because we can't use those other symptom control things. How do you know if the endo surgery is causing damage? Oh, I mean, the only way, I mean, that's really hard, isn't it? The key test of fertility is to try and get pregnant and see what happens. And if you're not getting pregnant, there's a problem. So I don't, you know, I don't know for you, if you had, you know, surgery when you were younger and, oh my gosh, has the surgery caused issues? I would try not to have that thought, because it's very unlikely it's caused problems. Very unlikely. You know, we take great care and attention to avoid damage. I guess what I'm meaning is more along that, if, you know, for a doctor, at first do no harm. So don't do anything if there's no clear outcome that you're trying to get. So that's what I mean. For someone who's not in pain, but is worried about endometriosis, well, I'd avoid treating it, because that person doesn't have pain or infertility. So that's kind of more I'm getting at, rather than, oh my gosh, has the surgery caused problems? You know, I'd hope that the surgery was done because you were having symptoms, okay? And if you've got symptoms, you're not getting pain control, it's reasonable to consider surgery. Diagnosed stage 4 endo after 2 surgeries, successful first pregnancy 3 years ago, but struggling to get pregnant a second time around, plus a return of symptoms. Yeah, good question. So got to individualize it here. Okay, so my general rule of thumb is I avoid further surgery to improve fertility. So in your situation, I would actively avoid further surgery with a view to improving fertility. But if you've now got pain and symptoms, well then, and that's causing problems, well, that just adds another pebble on the ledger. Okay, so we've got the, you know, avoid it, but hey, you've got pain. So we may be operating for someone like you with a view to improving your symptoms. And then hopefully it improves fertility as well, but it's probably in that order. You're operating to improve symptoms, and then in the hope it improves fertility. Okay. But I find, especially stage 4 endo, which is, you know, obviously, you know, bad endometriosis, I would not feel confident of restoring fertility with the previous second surgery. I'd be hopeful perhaps that we would improve your symptoms though. Okay. Would laparoscopy confirm diagnosis of endometriosis / infertility, Dr. Simon? Yeah, it should do. Yeah, I mean, infertility can be multifactorial. So there are sometimes more than one thing going on, you know, age, slightly low sperm motility, and endometriosis, for example. So if I did surgery and found endometriosis, I would be able to say, I think this is your underlying cause of issues, and I hope you'll be able to get pregnant. Does that make sense? But I'd need to look at sperm, look at the age and ovulation and egg reserve, and get a real good overall picture of it. All right. So you've got to individualize care. Diagnosed with endo when I was 14 and 17, now 21, looking at kids in my mid-20s potentially. How do I know when's the right time to freeze eggs? So probably what I'd do there is I would just be reviewed by a fertility specialist. I think you've got valid concerns given your history, and doing an AMH test and seeing a fertility specialist is reasonable. An AMH may not peak until you're about 25 though. Okay, so if you do an AMH now and it's lower, well, it might still be increasing. Okay, so an AMH has got to be, it's really got to be done, I think, with an appointment with someone who's a specialist in that field. You know, I know my GP colleagues, lots of my mates are GPs, you know, they know 1,000,001 things. AMH is 1 out of 1,000,001 things. As a fertility specialist, I only know maybe 50 things, you know, so it's much easier for me to know a lot more about AMH. So even in your situation, you've got to be careful about interpreting the AMH, okay? I would also look at where the endometriosis was. Was it affecting the ovaries? If you didn't have endometrioma, it wasn't affecting the ovaries. Look, I don't think there's necessarily an urgency to check your egg reserve and everything. You can create unnecessary anxiety by doing too many tests. So in your situation, if the ovaries were clear, look, I mean, I would even maybe look at checking egg supply and review with the specialist at sort of 25. But hey, you know, we'd always be very happy to see you and individualize things, look at it and have a discussion about things. Okay. Yeah, when is the right time to freeze eggs? Again, tricky. If everything's okay, my personal opinion is probably that early 30s, if you're not imminently looking at trying for pregnancy. I'm less inclined to freeze eggs or recommend freezing eggs for someone in their 20s, unless they've got significant, you know, egg reserve problems. But again, they can, you know, it's difficult to predict the future. Does the EFI graph determine the length of a person? No. So public funding, everyone waits the same amount of time, I'm afraid. So if you're eligible to go on a public funding wait list for IVF treatment, you just join the queue. And at the moment in Wellington, and it's regional, the wait list, at the moment in Wellington, the wait is around 15 to 18 months. It used to be about 12, but it has extended a wee bit, and that just reflects there's more people on the wait list. So the only people that jump to the head of the queue is those about to have cancer treatment, you know, that are needing, you know, eggs or embryos frozen because they're about to undergo something which will, you know, significantly adverse their fertility. Okay. Would you make acupuncture for endo pain management or fertility support? With regards to fertility, there's been quite a few trials. There's been some big trials done on acupuncture with IVF, and unfortunately, they haven't shown improvement in success. And saying that, lots of people find it bloody fantastic. They get improvement with their symptoms of pain. It helps them with the stress of the IVF process. So I'm totally cool for people to do acupuncture when they're having fertility treatment, but I don't believe the evidence will support that it improves fertility. But if it lowers stress levels, make people be able to get through that difficult process better. Sweet as. With regards to endo pain management, again, I don't think there's firm evidence of benefit. But you know, for someone who's suffering complex pain, you kind of got to try things, you know, and just see what works for you, you know, and that's about personally individualizing, you know, things. For some people, exercise is great. They feel better if they exercise regularly, avoiding alcohol, avoiding caffeine. They may have dietary intolerances. Certain foods are not allergic to them, but it just sort of sets them off. So there's, you know, you've kind of got to find out what works for you. So I'm not knocking acupuncture. I think go for it. You know, I think absolutely go for it. But is it something I routinely recommend to my patients? Look, I don't. But I'm very happy to support them, you know, going down that track. Are there any food that makes endo worse? Look, no. I think that there is no endometriosis diet or fertility superfood diet that is being proven to be, you know, helpful. People talk on anti-inflammatory diet and stuff like that. And look, I'm again happy for people to try those things. But does the evidence support that reducing pain or improving fertility? Look, I don't think there's enough to say that. I think that for many women with endometriosis, you know, as I mentioned before, they're not allergic to, say, I don't know, red onion. They're not allergic to red onion, but they are really sensitive to it. And women with endometriosis may become sensitized, meaning that what is a normal pain for this person, for a woman with endometriosis, that's a really bad pain. And it's because their body's sort of overreacting to everything that's going on, and that's out of their control. They're sensitized, and the nerves are damaged, and they're overreacting. So for someone with endometriosis, I think that they just have dietary intolerances. You know, it's gluten, lactose, dairy, you know, whatever. I don't know. So for many women, they need to maybe, you know, follow like a FODMAP diet and cut things out and see if there are certain triggers. Does that make sense? So that's my advice. I think there is dietary effect on endometriosis, but I think it's more around that sort of triggering thing. Okay. But hey, if someone talks to someone or they read something and they say, look, this diet works well, you know, I'm an advocate for giving it a go. Okay. You know, but I don't advocate a certain diet, but I think it's, you know, it's about finding what works for you. Okay. And if it works for you, well, that's fantastic. Cool. So I think that was the last question. 8 o'clock, so we'll shut things down there.
Yeah.
I hope that was useful. And yeah, thanks, Lydia.
Can you hear me there, Simon?
What, sorry?
Can you hear me there?
Yes, I can hear you. Yeah, yeah.
Great. Well, thank you so much, Simon. As you say, that does come to the end of our time tonight for tonight's webinar. Thank you so much. That was just so interesting and informative, and we've had an overwhelming response. There's been lots of questions that we haven't been able to get to, unfortunately. So for those of you out there that have had a question that we haven't been able to answer tonight, I recommend that you do check out either our website, fertilitynz.org.nz, or the Endometriosis New Zealand website, or please talk to your GP or your specialist and seek assistance in that way. I'm sorry we couldn't get to everybody tonight. But a big thank you, Simon. Really appreciate you taking the time to deliver the webinar tonight. It really has been really great. And please do check out our future webinars in the next few months. We've got a webinar on fertility preservation coming, also the ins and outs of public funding for fertility treatment, and also all you need to know about genetic testing. So is there any final comments from you tonight, Simon?
No, no, I think that the only comment I'd make is that, you know, sometimes we simplify things to make it easier for us, both as clinicians and as patients. So I think endometriosis is not one thing. You know, there's actually different types of endometriosis, and there's different ways that different types develop. So I think, you know, my one key comment is that we just need to individualize the care and look at the globe, you know, look at the overall situation. It's very easy to find little things. Oh, yeah, I've got that, that means I've got this issue. But I think, you know, it's important to sit down with someone and really tease out what the problems are and what the potential solutions are, both from a pain management point of view, but also from a fertility point of view.
Thank you so much, Simon. And thank you everybody for attending. And we hope that you have an enjoyable rest of the evening. Goodbye.
Ka kite ora. Bye.
Ka kite.